Hi guys, this is Jody and we're going to talk about the hematologic system. So the first drugs that we're going to talk about are iron, vitamin B12, and folic acid. These are drugs for anemia. What you should know about anemia is it is a reduction in red blood cell production. We know that red blood cells carry the oxygen to our organs and our tissues. If somebody doesn't have enough red blood cells, they're going to be more fatigued. They might get dizzy. We have to consider other things like rest periods before activity. And we also want to make sure that they are getting, if they're iron deficient, or even if they've had like blood loss due to, like say, a GI bleed or surgery, we know that iron is going to help with red blood cell production. So we'd want them to increase iron in their diet as well. So this would be meat products. Your red meat has a lot of iron in it, as well as some of your greens. And you guys can pull lists of foods that are high in iron. So if we're giving them a pill form of iron, this is a tablet that can cause some pretty significant constipation. So we want to make sure that they are drinking a lot of fluids, getting enough fiber in their diet, out and being as active as possible. This medication does turn the stools a dark green or black. This is harmless. Now it is something to think about if a patient is at risk for a GI bleed. GI bleed tends to be more of a tarry black stool, but we would want to definitely be able to differentiate there. Because it can cause some iron toxicity, we want to make sure that it's out of the reach of children. Food does decrease the absorption of this medication, so it is best if they can take it on an empty stomach. And it will leave like a metallic taste in a client's mouth, so they can chew gum or suck on candy. You may have some clients with something called pernicious anemia, so they don't have enough B12 production, so they're B12 deficient, so we can give them injections of vitamin B12. This is a lifelong treatment for somebody who has pernicious anemia because they need that B12. We do with B12 want to watch for hypokalemia, so that's low potassium levels. And then folic acid, you'll see prescribed a lot in the hospital for clients who come in with a history of alcoholism, who drink a lot because they tend not to have enough folate. They're deficient in folate, so we will give them some folic acid. And those all help with the production of red blood cells. So bleeding disorders, you may hear of somebody with factor V or hemophilia, something that causes a type of bleeding disorder. The module gets into factors 8 and factors 9. So if a client is not producing these clotting factors, these coagulation factors, we then give them these factors. They can cause an allergic reaction, so if you were giving it in a hospital setting or a doctor's office setting, you would want to have epinephrine available. Desmopressin is given also for factor 8. It stimulates the release of factor 8 in a client's system. This is an anti-diuretic hormone. So you guys learned about diuretics, and what diuretics do is they help clients pee off extra fluid that they might be holding on to. This is anti-diuretic, so it actually it helps to keep the fluid in the vascular space. There is a disorder called diabetes insipidus, which is not, it has nothing to do with blood sugar. Diabetes insipidus is when you will see clients, it's usually if they have like a brain injury of some type, brain tumor, head injury, they actually will, they get this hormone and it stimulates the release of a lot of fluid. So they'll be urinating a lot and it'll be very dilute urine, so very large amounts of urine. So with those disorders, we can give desmopressin, which actually is an antidiuretic, so it helps to keep that fluid in the vascular space. Because it's doing that, we need to watch for fluid retention and hyponatremia with this drug. So if you think about it, if you think about now we're keeping fluid into the vascular space, it's going to dilute all the electrolytes like sodium and that type of thing in the system. So that is desmopressin, and again, the reason it would be given for factor 8 is because it stimulates the release of factor 8, which is a coagulation factor. The most popular drugs I think that you will talk about when we talk about hematologic drugs are anticoagulants, okay? So we are going to talk about more and more, I can tell you when you get into semester 4, is anticoagulants, antiplatelets, and thrombolytics. So with anticoagulants, you will often hear these termed as blood thinners. But they are not blood thinners. They do not thin the blood. What they do is they prolong the time it takes your blood to clot. Okay? So the most popular drugs that you hear about here are warfarin and like apixaban. Okay? Clients that might be taking these may have a history of deep vein thrombosis, so blood clots there, or pulmonary embolus, or clients who have something called atrial fibrillation, which is a cardiac dysrhythmia that is fairly common in the older population, but that dysrhythmia puts them at risk for strokes, which essentially is coming from clotting that can happen in the heart chamber itself if a client has AFib. So we may be giving them anticoagulants to delay the time it takes the blood to clot. Okay, and so depending on what type of anticoagulant they're on, if they're on warfarin, which is an old school anticoagulant, which you still see prescribed today, it is a cheap drug, and there are certain procedures that clients have where the only anticoagulant they can be on is warfarin. With warfarin, they have to have routine blood draws for PT-INR. Okay, to make sure that they are therapeutic, that they're getting enough of the drug, but not so much that we're prolonging that clotting time too much. Okay, so those are anticoagulants. Antiplatelets, don't get confused with this. They do not reduce the amount of platelets. Okay, it would actually be an adverse effect if we saw somebody with significant thrombocytopenia who is on an antiplatelet. What the antiplatelets do is prevent the platelets from sticking together and forming a clot. Okay, so they kind of make them a little more slippery, so they just kind of slide against each other instead of sticking together and forming a clot. Okay, so those are antiplatelets, and we'll talk about clopidogrel is a big one that you'll see. We'll talk a little bit more about those. Thrombolytics dissolve clots. Okay, it's basically like the Drano of blood. If there's a clot, it dissolves it. Now, there are very significant adverse effects to thrombolytics, so these are not used lightly. Okay, and there is a time frame that we would use these in if somebody was having, say, a stroke, or if they were in like maybe a very rural hospital where they couldn't get them into a catheterization lab. They may try TPA to dissolve the clot to get perfusion to the heart. But generally, when you see TPA around here in Rochester or Buffalo or more area where we're pretty close to some bigger hospitals where they can get to a catheterization lab if it's somebody having an MI, where you really see this used is for patients having stroke. Okay, so we have to remember with stroke, time is tissue. So if somebody is having symptoms of a stroke, as soon as those symptoms develop, we want to get them to the emergency room as soon as possible so that we can determine whether or not it would be safe and if it's appropriate to give them a thrombolytic. Okay, which would be TPA is the big one that we give with that. So really not, the thrombolytic would only be given in emergent situations in a hospital setting, whereas the other two, anticoagulants and antiplatelets, you can see patients go home on these medications, and you'll see them a lot if you work on a cardiovascular unit. So the ones that we're going to talk about are warfarin. So warfarin is your Coumadin. Again, this is an old school drug. And basically, you know, we used to tell clients a long time ago to avoid any foods with vitamin K. The problem with telling clients that now is we know that vitamin K is the antidote, so we'll actually counteract the warfarin. However, foods with vitamin K are very healthy, and we can always adjust dose as needed. So with vitamin K, the most important thing is to advise somebody to be very consistent when eating foods containing vitamin K, like leafy greens. So if a patient likes to eat a side salad 3 times a week, then we would just say be consistent with eating that salad 3 times a week, and your dose will be adjusted accordingly based on what the lab draws are showing. Because this prolongs the time it takes for the blood to clot, clients are more at risk for bleeding. So if they do cut themselves, if they end up with an internal bleed, like a GI bleed, something like that, they are more at risk for bleeding out and becoming hypovolemic. So if you had somebody like in the hospital that was on warfarin that had an IV in, if you were taking their IV out, you're going to have to hold pressure to that site longer because it's going to take longer for that blood to clot. It will clot, it just takes longer, okay? So we would instruct on bleeding precautions, soft toothbrush, electric razor, avoiding any activities that would put them at risk for bleeding and bruising. Okay, so like if they're hockey players, probably not the best for them to be playing hockey if they're on warfarin, okay? They will need to have their PT-INR checked regularly. So normally our INR is going to be around 1. Somebody on Coumadin, or warfarin, we want them to be between 2 and 3. That would be considered therapeutic. If they're above 3, then it's taking way too long for their blood to clot and they're very highly at risk for bleeding out, okay? We want to watch for interactions with other drugs. There are drugs that will impact the warfarin levels. Antibiotics are one. If we have clients on antibiotics, it can really mess with their INR levels. So we would want to be checking their levels more frequently and doing dose adjustments as needed. If they were to come into the hospital because their INR is really high and they're highly at risk, then we can give them some vitamin K as the antidote. Okay, and then like I said, the important thing is for clients to be consistent when they're eating foods containing vitamin K. Enoxaparin is an injection. This is a sub-Q injection that you would give to a client. This one, there's some administration things with it. So when you get the syringe with the enoxaparin, you know how if you guys have been taught IV stuff, or when you're, injecting something into an IV, you want to tap out the air bubble and get all the air out. Well, with the enoxaparin, this is actually something when you go to give the medication, you want to tap the air bubble so that it is right above the medication and between like the medication and the plunger. So it would actually be, as you're giving the injection, you would push the air bubble in last, and that kind of pushes it down and locks it into the tissue and will prevent some trauma and bruising at the site. So you can actually inject that into the sub-Q tissue. So we want to push that air bubble in last. Again, bleeding precautions, just the same. We're prolonging that clotting time. And it may be used to bridge to warfarin therapy. So an example of that is this. If you have a client who has a deep vein thrombosis and they're doing like a hospital ED aversion program, they want to send this client home rather than having them in the hospital on a heparin drip for a prolonged period of time. So they will send them home with enoxaparin injections, and that will prolong the clotting time until their warfarin is in that therapeutic range. So again, like I said, normal range is 1, and if we have somebody on warfarin, we want them to be between 2 and 3. So until we get to that therapeutic level with the warfarin, we would do the enoxaparin injections. Now, there are other drugs out there where we don't have to worry about levels like Eliquis and stuff like that, but warfarin tends to be a very inexpensive drug, which is why, like I said, it's still used. And then there are certain procedures that a client has where they have like mechanical valves put in, or clients with ventricular assist device where they have to be on warfarin specifically. So it is still used and prescribed. Antiplatelets, again, these are the drugs that prevent the platelets from sticking together and forming a clot. And I just want to emphasize again, it does not mean that we are reducing the number of platelets. So if we saw somebody who is significantly thrombocytopenic, which means low platelet level, that would be an adverse reaction. Okay, because really what we're just doing is preventing those platelets from sticking together. Again, still bleeding precautions, soft toothbrush, electric razor, notify the provider if you have any significant bruising, bleeding, that type of thing. Watch for thrombocytopenia. So if you had a client who was on this and they're coming in and they're bruised like all over their arms and all over their legs, and they're saying, I don't know where I got all these bruises, then you would expect that they're going to have their blood drawn and they're going to look at their platelet level. We will talk about this one a lot in fourth semester when we talk about people going for cardiac stents. A cardiac stent is, it looks like a little pen spring is what it looks like, and it's put into a coronary artery to help stabilize a vessel after we balloon it to open it and get better perfusion. They can put this in. Well, that's a foreign body we're putting into the person's coronary artery, and the body's natural response is to throw platelets at it. They're like, oof, this is not normal. That's a normal response of the body, but we don't want those platelets sticking together and clumping and forming a clot on that new stent, which would then put that client very high risk for having a heart attack. So like I said, we will talk about those more in fourth semester, but it's very important for you to know that a medication like clopidogrel is preventing those platelets from sticking together. Okay. Thrombolytics. So this is a medication that, again, you might see if a patient comes into the hospital with stroke symptoms. So if you work in a hospital or when you're in the hospital for clinical, keep an ear out. If somebody comes into the emergency room or is on a unit and all of a sudden develops symptoms of a stroke, what you are most likely to hear is stroke team called. Stroke team to the emergency room, or stroke team to whatever unit the client is. Because once that client has symptoms of a stroke, they are on a clock. We are looking at time because time is tissue. And what we want to do is get perfusion to that brain so that we don't end up with these very long-term deficits. Okay, so if you know anything about stroke, you know that a patient can have a stroke and have very minimal deficits, or you can have somebody all the way from coma to death having had a stroke. So time is tissue. So if somebody is having, say, a stroke, we want to dissolve that clot in their brain if that is the reason for stroke. Now, there is other stroke that is hemorrhagic, which is bleeding. If they're having a hemorrhagic stroke, then TPA would be contraindicated. Okay, so this is for ischemic stroke, one that is caused by a clot. Okay, so we can give this medication to dissolve that clot. So what you will have is that stroke team called, and they look at this patient. They do a CAT scan of their head to determine that they are for sure having an ischemic stroke. If that is the case, they'll look at the patient to weigh the risk-benefit, because we do know with thrombolytics there is very high risk for bleeding, bleeding into the brain even. So we have to be very, very cautious. So if a client receives TPA, there is a time frame that is generally anywhere from minutes up to 3 to 4.5 hours. Depends on what resource and what facility you're in, whether or not they're going to push it to that 4.5 hours. And the reason for that is after that 4.5 hour time frame, the risks begin to outweigh the benefit. Okay. So if a patient is to receive this, they are going to be either in an emergency room or on a stroke critical care unit, ICU, something like this. This is not something you would be given on a general med surg floor, right? If they got it, they're highly at risk for bleeding. Like I said, we want to make sure they're not bleeding into the brain, so we'd be doing very frequent neuro checks on this patient. We would assess for bleeding and bleeding risk before administration. Now, let's say a patient has a history of a GI bleed. That does not mean that the stroke team would not determine that, yes, we are going to give this, because their risk of a GI bleed or further GI bleeding is not as high as the risk of death if they stroke or they continue with these stroke symptoms, or they end up with very lifelong disabilities related to the stroke. So they really weigh the risk benefit for the patient when they're giving this. After it's given, we want to avoid doing any venipuncture or injections for at least an hour, because it is going to be very difficult for them to clot, right? They're very high risk for bleeding. So again, this is your clot buster. Really, the reason you're going to see this given is in an emergency situation for a stroke or an MI. The reason it's not done as much for MI is because we have the catheterization labs where they can get in, deliver that, more locally if they can during a catheterization procedure. And you guys don't have to worry about that. That's something you'll get more into in fourth semester. And then the last thing we're going to talk about with the hematologic system are drugs to support hematopoiesis. Erythropoietin is one that you may give. So erythropoietin is what the kidneys produce to stimulate the bone marrow to produce red blood cells. So you may see clients who have kidney disease who are significantly anemic because their kidneys aren't producing enough or any of this erythropoietin to stimulate that red blood cell production. So if not, we're going to give them erythropoietin. I can never say this like quite correctly, but this is going to stimulate the production of red blood cells, okay? If you give this, you're not going to shake the vial. You're going to check for cloudiness. Don't administer it if it is cloudy. This can cause increase in blood pressure, so you would want to monitor blood pressure before and after therapy. It's very often given during dialysis if a client is a kidney patient who is on dialysis, okay? And then there's filgrastim. This increases the production of white blood cells or neutrophils. You may see this with patients who have cancer diagnosis. If a client is on this, we'd be looking at their white blood cell count for a therapeutic response, okay? If somebody is having to take filgrastim because they're not producing enough white blood cells, we know that the white blood cells help fight infections, so we would just want to make sure that we are teaching to any prevention of infection, avoiding crowds, washing hands, getting vaccinated, that type of thing. Okay, and that's it. If you have any questions, let me know. Otherwise, make sure that you are going through the module and doing the activities. And then again, I would, these meds for week 6 and week 7, cardiovascular and hematologic, are pretty heavy, but they are meds that you will likely come across in practice quite frequently. Okay, so they are very important. If you have any questions, let me know. Thanks.